Welcome to Vitals and Values. And today we are talking all things imaging, and we have a guest.
You do.
So we are welcomed with Jon Runquist from the Imaging Center here in Grand Rapids. And tell us, Jon, a little bit about yourself, your journey, and how did you enter healthcare?
Well, it's kind of a long journey, but I'd been kind of a serial entrepreneur for years. And after COVID, I left the big city and came to Grand Rapids. I'm from the mid-Michigan originally, and hooked up with a handful of development partners. And they said, hey, they happen to be in the medical industry. And they said, we're going to put this thing together, and it's called an imaging center. And we really need some help kind of building it and operating this. Would you give us a hand? And I got involved at the kind of the grassroots and just kind of started working on this and realized what a monumental task that was in this side of the state, and realized how it kind of got me a little riled up, because just the monopoly on imaging, which almost everybody needs. So we started to go on this path, and we're the first independent center. We've opened 2 centers in the last year. On the west side of the state.
Awesome. Love that. Thanks for being here with us.
Thank you very much.
What we like to do in this podcast is we start with what we call the vitals check.
Okay.
So we like to give a little bit of data behind whatever topic we're talking about. I was doing some research on imaging, and it was hard to find data. At least I had trouble with it. So I don't know if you have data, but what we do know is that research shows that imaging in hospital systems can cost 3 times as much as imaging in outpatient offices or other facilities. So that's one piece of data I ran across. And
all right.
You look like you have thoughts on that.
I'm ready to go for that. We could do the whole segment in that.
Okay, well, that was my main piece of data. And then I also found that there are multiple studies that have documented that physicians, as they increasingly become integrated vertically into systems, so they become part of this larger system, that there's a shift in where the imaging is performed, and you get a lot more hospital-based imaging, which makes sense. And that kind of goes with that previous piece of data about how the cost then seems to be going up. So you look like you have thoughts.
Well, I do have thoughts on it. And I think they're thoughts that probably a lot of people that need imaging don't ever really delve into. And we had to get it. So in the state of Michigan, you have something called a certificate of need. So to be even able to get an MRI or a CT like that, you have to get a handful of independent doctors that will basically say, we're gonna supply you with scans. We want to send our scans to you, and you have to build up a database of a certain amount of points to be able to qualify one through the state. And what happens with big hospital is that so the state collects this data on a quarterly and semi-annual basis for both MRI and CTs, and that's really what we're basically talking about here, MRI and CTs. As soon as the community hits a certain level where they need another MRI or CT, it's common for the local hospital center to go out and apply for those points, get qualified for them, and pull it and put them on the shelf. They don't get another machine, but they restrict anybody else from getting those points. So that's kind of a bummer. Independent imaging on the east side of the state of Michigan, there are like 25 of these locations. Over here, we're the first ones. And, I think your data is a little bit skewed on the pricing. We're about 20% of what the hospitals charge.
Oh, wow.
So if you need a standard, you hurt your knee and you went in, for us, that's probably like $380, $400. That could be $2,500 at the hospital. And they'll send you to different locations. And, so it will take a few weeks to get. So we had a great group of specialists in this area, and Grand Rapids is fairly lucky. However, a lot of doctors are starting to become hospital employees, so they dedicate all their points to the hospitals. And I think a lot of people, they kind of take that for granted. And I think there are a group of savvy, independent physicians in this area that said, hey, we really need this. And I think if you remember a year ago in this area, to get a read from a radiologist, there was a real radiology shortage. So it was going to take 30 days, 40 days, 50, 60 days sometimes to get a read. So you have something seriously wrong with you, unless you're in the ER and it's emergent and you have a sucking chest wound or something like that. But if you have a bad knee and you can't walk, you're waiting 3 months or sometimes, 30, 40, 50 days to get a read.
I think this is crazy because, oh, sorry, David, did you have something?
Here's a question. I'm just intrigued. There's like pros and cons to everything. In my world, I will admit uh, I'm a libertarian at heart, which is like, why do we have more oversight? Like, I understand some, like my dad's a cardiologist.
Right.
Funny enough, when we were talking about this subject, he made comment. He goes, oh, we had to deal with that with cath labs 25 years ago. That whole idea of certification of need. I think it's ridiculous. Is there an argument for the other side? I don't see it. But what is the argument from the other side to try to regulate it? I don't understand it, but what's their argument for trying?
I think, at least in the state of Michigan, and if you look at all 50 states, some states have a certain level of certificate of need. I think was your dad in Illinois? You guys were at Illinois, right?
Grand Rapids. He was
Grand Rapids. Okay, I'm sorry about that. I thought thought there was some Illinois background there. I think it started
from Illinois.
Yeah. I think it started on the east side, kind of with the unions, and a lot of the independent imaging really started with the auto no fault stuff. So it used to be that a lot of these independent imaging centers weren't really driven for medical purposes, but legal purposes. So they could go ahead and apply for these centers and build them on the corner. They'd have to wait a handful of months, but they'd get $5,000 or $6,000 or $10,000 for some of these exams. But I think they think it's for a good purpose so they can regulate it, but it is, I agree with you. It's over-regulated. I now that we have one, of course, I don't mind it because it obviously it's a difficult mountain to climb, but in the same breath, it really should be much more. It's not patient friendly at all. And it allows the hospitals to basically create a monopoly on these.
Because I've been working in healthcare for the past decade, and I had no idea this was a thing.
Right.
Never heard anything about this, and I just assumed we just referred to the hospitals because I didn't know why we didn't have imaging centers. I guess it never occurred to me.
I think everybody has that same viewpoint. I don't think that anybody thinks it's anything different. You're going to go where your doctor tells you to go. And in this area, specifically in the Grand Rapids area, there hasn't been an option. So everybody's gone to the local 3, big hospital networks in the area. And again, we're the first guy here. So we're trying to change referral patterns and change, hearts and minds. And for the astute patient who understands what their insurance pays for and what it doesn't pay for, they're knocking down our door to try to get things handled. And part of our issue is that the reimbursement from not only the healthcare industry from commercial insurance, but Medicare and Medicaid are very, very difficult for the independent insurance or the independent imaging center to handle.
Sure. I feel like that's the case in a lot of other areas too.
Right. I don't think we're exclusive.
Lara, that has nothing to do with why you started concierge medicine.
Yeah, not at all. Though, unfortunately, still in concierge medicine, we have to still deal with insurance for things like imaging. But the great thing about the imaging center is that you do a lot of that for us, from my understanding.
Absolutely. Yeah. So we will do any of your auths. So if you have a patient with an insurance, a commercial insurance, we'll do the insurance authorization for you. We try to make it an easy one-stop shop. We have 2 centers now. So we have 1 MRI, 2 CTs. We do, I think, David, your dad would like this. We do a handful of specialized cardiac imaging. So for plaque and FFRCT, which is kind of a specialty above and beyond. So if you have a CCTA, which would be a cardiac CTA, and you show some ischemia or some blockages, you can go and do some extra imaging for 3D. It'll give you a 3D image of your heart and show where the blockage is, and not only where it is, but what kind of plaque it is, which is very helpful for the cardiologist if they do have to go into a cath lab at any point in time. So it's a whole different ballgame, but we'll do the authorization for you, and we try to get them in and out. For right now, we try to get people in within 3 to 5 days, depending on their schedule when they can get in. And our reads, like, kind of the vast majority of reads on the west side of the state, we turn around in 24 to 48 hours.
Yeah, I try to refer everyone to you that I can if I need imaging. And people get in quick, and the results are back like the next day half the time.
Right.
So it's been really an amazing resource for our patients.
I can't, when we sit back and you talk to some of the people that would like to refer, and, some people like to say, well, we like to go to the hospital and we like to do this. The equipment is the exact same. The radiologist that reads the report is a fellowship trained. We have a group of fellowship trained radiologists. They're as good as you can get. It's cheaper, it's quicker, and it's more convenient to get in. You park, you walk in, you don't have to go down to the basement of a hospital and walk down the narrow hallway. And you would be surprised how many people are claustrophobic about getting in these machines. So we've built our spaces to be kind of med spa like. They're open, they're airy. You don't get that feeling of dread while you're sitting there waiting to get into the MRI. So we try to be a patient-focused scenario, and I think it's working.
Yeah, I've been to both your locations now, and they're beautiful.
Thank you.
Does not feel like you're in a healthcare setting, which is great. Because
Right.
patients do not want to drive downtown. I hear that all the time. So it's really nice that you're in a different spot for them.
Yes.
I
Well,
would say my experience of an MRI, my last experience of MRI was one of those the transport ones where you're in the back of a friggin' like semi truck, and I'm like, this is weird.
Well, you do.
We do have a semi truck. So here's the situation with it. Yeah, but that's not. But I don't take offense to it. Most of them are, unless you have so they rate MRIs by Tesla strength. So there's a 0.5 Tesla, a 0.75, a 1. We have a 1.5 Tesla, which is the largest magnet to put in a mobile trailer at this point in time. If you needed some really in-depth, like prostate exams, or that would be a 3T, that would probably pretty much have to go to the hospital. But here's the funny part. And the reason they're mobile, David, is because along with the CON, the state makes you move it every year. So you can bring it to your facility, but you can't keep it there. You need to drive it to another location
For how long?
a period of time, a week, 2 weeks. I forgive me if I don't know the exact time, but yeah, it's an insignificant amount of time, but significant enough that it has to go.
Why?
So fascinating.
Yeah. Why do they make you do that?
Well, so you get this is another thing with it. I guess I'm so used to looking at this stuff recently that it seems normal to me, but it really isn't. So you have to get a certificate of need to have what they call a host site. So for us, the facility where we have our MRI is called an MRI host site. That just means you can pull a truck. That doesn't mean that's a certificate of need for the actual truck. Then you have to get we call them mobile coaches. It sounds a little better that way. Then you have to get what's called a CSC, which is a Central Service Coordinator, to be able to drive the truck around. So the CON is involved with the magnet and the truck. That's one CON, and the other one is for the host site for it to go. So every truck has to have 2 host sites to go back and forth. And I think the background behind that was really to make sure that it was servicing all areas of need. So if you had an area that didn't require this and you were just there to profit or do whatever, they would kind of make you go to areas where they think the assistance was needed.
That is so
I just sit there and go, I just don't get it, because I'm just like, well, if there's no need, they're not going to make money. So why does the government have to force it? I don't under. You're as libertarian as I am about it. I really do, and I do feel like it doesn't help that when we talk to commercial payers and we talk to. I recently kind of went up the flagpole with a couple of our local political people. We spoke to Hillary Skolton's group in DC and John Molinar, who are our local representatives in the area in Grand Rapids. It said, hey, look, guys, the disparity between what Medicare gives us, and I believe in Medicare and I believe in Medicaid and I want to help everybody, right? But we don't get subsidized by the government at all. And yet we're forced to get a CON. We have to take those patients, which is great. But it doesn't become government subsidized Medicaid. It becomes private practice Medicare and Medicaid. And we take them all at the same rate. But at some point, the hospitals get appropriations money and they get subsidies to be able to help that. It's certainly they offer some services that we don't have to offer. But at some point, it seems a little slanted. And we're not looking for 100%. To be right in line with them, but a little bump wouldn't hurt. I mean, we're really fulfilling a good need. We're doing about 1,500 scans a month at this point in time. So was that 18,000 scans a year? That's a lot of people.
And I think the biggest thing for patients that I see is the price point. And I mean, there's insurance, and you, like you said, you do the auth for that. But for patients that either can't get it covered or don't have good insurance or high deductible, we've
Yeah.
run into you are so much cheaper for them than
Right.
if I send it to the hospital.
It is. So we offer a self-pay rate. So we have a rate that is, I mean, most people today, to be able to afford insurance, which is its own um, difficult situation in my view, right? I mean, the numbers keep going up and up and up and up. I mean, to be able to get affordable health insurance for the standard Joe, the Smith family, they probably have deductibles of 8, 10, 15. I've seen $22,000 deductibles. So if your doctor says, "Hey, you need an MRI on your hip, let's get you in," and they send you to a medical facility that isn't an independent facility, that could be $3,000 or $4,000. Now that's all coming out of your pocket until you meet your deductible. For us, that same scan is probably $500 or $600.
Well, because so my sister had an MRI of her hip last year.
Oh, did you?
Yeah.
Okay.
And she did not with you guys because we didn't know about you yet.
Right.
But
Okay.
it was through the hospital system. And I think she had to pay with her insurance $1,500.
Yeah.
And we looked at your pricing, and I think it would have been out of pocket $500. Like you
Oh,
said.
yeah. And probably had to pay a professional fee on top of it, right? So that's probably
Probably.
just the only technical fee. So she probably got another bill for a radiologist for a couple $100 after
I
that.
think she kept getting bills, and that's the thing.
Right.
Bills just kept coming, and she's like,
Yeah.
"What is this for?"
You don't know. But I will say, listen, I've gotten to know you guys through the years, and I really think what you guys are doing in medicine is amazing. And you were kind of early adopters. I mean, when we were just opening the doors, you guys were like checking us out,
Yeah.
saying, "Hey,
I did
I
not
want to
know
find my
that.
place." Right.
Well, it's funny because we hadn't even opened our doors yet.
Right.
And we're like, where are we going to send people for imaging?
Right.
Like, we knew the hospitals. And I literally just Googled this, and you came up. And I didn't know you were new at the time. I thought you'd
Right.
been around.
Hey, the SEO stuff does work. I
It
know that
works.
guy, right?
No, so it's been great for us.
Right.
It's
David,
so
have you ever?
fascinating.
Yeah. So you've
was that?
had an MRI. Have you ever had a CT or anything?
Actually, so I did have a CT years ago.
Okay.
Because I had, when I was like 12, 13, I had obstructive sleep apnea.
Okay.
And they did a full CT scan to figure out what was going on, why was I stopping breathing. They went through that whole process. And I had a cyst on my pituitary gland during the obesity phase.
Okay.
And so I had a brain CT done. And that, so I've done a couple different things over the years, but it's been a decade since I've
Right,
had mostly
right.
any imagery done.
Do you remember going in the tube? Do you remember?
Oh yeah.
Were you a big kid getting on there, or did you feel all right?
I was a big boy. It was that they had to put the pillows around the side of me because I was like squeezed in like this.
Okay.
and-
Yeah, I get it. I get it. But
no,
we
it
do.
is
Yeah.
keep going.
No, go ahead. Go ahead.
No, I was just saying, with like on the billing side, I just find so fascinating. It's like, here's my dad who spent 30 years in cardiology, all this kind of stuff, and seeing the sequence of events of all that kind of stuff. And come to find out, like, now he's outside the system, he's retired, and he gets these medical bills, and he's like, I was a doctor for 30 plus years. This is what I did. I don't even understand how this billing works anymore. Like, you look at sometimes these big systems and how they medically bill, and it's just like, I don't understand it. It's if a doctor who's went through this system has been getting so confused on it, I couldn't imagine what the average person is dealing with.
I will tell you that aside from getting the certificate of need, I mean, if you look at the business model as whole as imaging, right? It's like a Kinko's, right? It's Kinko's for humans. You're just making copies of it, but it's way beyond. It is probably one of the most complicated businesses that I've ever been involved with. The CON itself was tricky, right? That's all legislative and all kind of technical, and they just formulaic and whatever. When you start talking about medical billing, it's in pure insanity, because every different carrier has a different rate, and every different carrier has a different way that they pay things. So as an example, if we were servicing a spine guy and they said, hey, listen, we need to do 3 MRIs of your back, cervical, thoracic, lumbar, you get on and hypothetically say those are each at our facility $400 a piece. So that's like $1,200 for 3 scans. It takes up 3 things in the scanner. The way it works, it's called the multi-scan rule. And if you're doing a scan on the same body part, you get 100% for the first scan, 50% for the second scan, and 25% for the third scan. So what the hospital would get, several $1,000s for, we end up getting, $550, $600 for. It's really slanted.
Wait, so why does that not happen to them?
Well, it does, but they get more money for the actual scans anyway. So, yeah, I mean, I guess their point is they're already in the machine, so you're not resetting it. So you're already there, so let's just do it. But it still takes a long time to do it. So for us, we're very much a volume-based business, and we're very into patient care. Our center director used to work in the big hospital network and is happy to be on the independent side, but there's a lot of care there. So we try to instill every opportunity we can to advance the processes of how to get people in and out. So as an example, for our MRIs, and I mentioned to you, is it a tight squeeze going through the tube? We have the widest bore MRI they make. And it's called it's a shallow throat. So it's not like a long tube. So if you're ever in there, your feet or your head will be sticking out of either end. You're never
I was all the way in.
Right. Yeah. You went deep. You went deep that time. Okay. And we use an AI platform called Subtle MR. And Subtle MR, specifically for our MRIs, reduces the noise. So it takes some protocols, reduces the amount of pictures that you need, fills it in through AI. And so it can do like a 40-minute scan in 18 minutes with better results. It's really quite amazing.
It works out perfectly because I'm fast, because you alluded to it earlier, and
Right.
that kind of okay. ChatGPT is like my
Your go-to?
it's my side chick, and
Right.
we have a very, very close relationship. And so AI, and I do find it fascinating from like a imagery standpoint and the need for radiologists and all this kind of stuff. Where is that looking like? I'm so fascinated. Where is AI? Is it the doom and gloom where pretty much radiologists are going to not exist in 5 years? Or is it like, where is that line?
Do you know what? I think it depends on who you're talking to, right? So I think some scans are more nuanced than others, right? So I think if you look at plain films, X-ray, and funnily enough, if you ever buy a radiology setup for a radiologist going to read for you because you provide that for them, the most expensive monitor is for X-rays. For some reason, they just need the most expensive monitor for that. Anyway, I think if you're doing bones and ortho and things that I think are fairly, simple to interpret, you can. When you get into more complex chest, abdomen, pelvis, you're looking for tumors, you're looking for obstruction stuff. I don't know that they're going to run away from that anytime soon, but I think they're certainly going to be taking over shortly. And I think there probably are still. I mean, look, when they read them, they use a lot of AI just to read them. But they're still putting some eyes on them.
So you don't think
I just find it.
Yeah, you don't think radiologists are going to be gone in 5 years?
5 years is a long time with AI. I mean, I mean, 2020, they're going to make it to 2026. I'm 100% certain that they'll make it into 2026. I don't know what 27 looks for them though.
I sit there with my dad and like talking about when he would look at EKGs and stuff and everything. I'm like, you can't tell me that's not going to be done better with a computer here, if not already. Yeah.
Unbelievable. I bet you he kind of looks at these images and thinks, my God, I mean, when I was in practice, I was like listening to a cassette tape, right? I mean, the image quality has got to be that much better. And
because he was intervention, so he was doing
he was an
stuff.
IR.
That's where he was. Yep. Yeah. And
Sorry, go ahead, David.
oh, you're good. Yeah, I was just telling that.
Well, I was going to say, speaking about the cardiac stuff, one of the first things that you guys talked to me about when I first met you was the advanced cardiac testing, which is super amazing technology to be able to look at a 3D image of the heart and move it around.
Right.
And see right where plaques may be. I mean, that's an amazing technology. Now, my one issue with that has been the insurance coverage isn't there, so it's pretty expensive for patients.
Well, it's funny you should say that. So I just got a notification today, let me say earlier this week. So the whole thing stems from, if you're looking for advanced cardiac care, you come in for a CCTA. Most people's insurance will cover a CCTA. If you don't have it, then we offer a reasonable price for that. They take all this, so your CCTA is a contrast study. So you come in and we have power injectors, so you'll get an IV and you lay down and, you get your heart rate down to below 60 and they'll start, hold your breath and come in and this is on a CT scanner. And then they'll do the power injector and put the contrast in you. It'll make you feel like you're going to pee your pants a little bit. You get a little warm and fuzzy, and you go, so that's about a 20, 25-minute scan. Once that gets done, the way that our system is set up is we have 2 advanced cardiac AI platforms. One is called Clearly and one is called HeartFlow. They are a little bit of competitors. They do one thing a little bit better than the other one. So if your CCTA goes through one of our AI platforms and it'll come back and say, hey, do you have a blockage? Do you have ischemia? And if it's over like a 40% blockage, then it would suggest, hey, let's get a plaque analysis or let's get an FFRCT, which would show the functional flow if you've got a blockage of where your blood is going. Those are both now. What I heard as of January 26, the plaque will be covered by insurance. Medicare, once Medicare picks it up, everybody falls in line.
Sweet. Well, that'll be great.
And the FFRCT is already kind of being covered.
Okay.
So, right now when it's new, they put modifiers on a CPT code and it's kind of hit or miss. And it's not cheap. It's not cheap to do it. But do you know what? If you're saving lives, it means a lot. Before, no one could do it. I think most of the time, you could probably ask your dad, David, if they did a cath lab, they went in there a little bit blind. This, you can see exactly where the blockage is. And I think to most people's, I think the amazement there is that you get a whole a pamphlet with it, but it shows you what kind of plaque you have. And I think a lot of people think that's even more important to understand. Is it the hard calcified plaque, which is going to stay where it is, and you don't really need to worry about it? Or is it the softer malleable plaque, which is going to maybe break off and cause an issue,
more issues?
So
yeah, because that imagery of knowing ahead of time. So my dad used to tell me, because he was quite the early adopter to intervention, and so they didn't have the specialty tools yet when you're doing angioplasties and you're running lines and all this kind of stuff.
Right.
And sometimes he'd have patients where they just had a really goofy turn in like an artery that just threw things off for a loop. And so it would take him, he'd have to pull the whole thing out, bend it a little bit, put it all the way back in again. And it was like a game. And sometimes he'd talk about how he'd have this one patient that would take 40, 50 minutes longer than expected because he's got this just goofy turn. And I just find it fascinating. He used to put it in a little plastic baggie and say, hey, keep this, because if you ever have to get opened up again, this is going to save the next cardiologist a lot of time. And he would give it to him. Now they have all these different tools and stuff.
Are they sure? So he just walked in with it in his pocket in a little Ziploc baggie. Says, hey, here you go. By the way, don't charge me $4,000 for that other one. Don't write that one down. Don't check that one in yet. I got my own head on me. Yeah.
Yeah. It's like, hey, a cardiologist 15 years ago gave me this. Here you go. And now it's that's not necessary anymore.
That's crazy. The advancements are coming fast, and I can't imagine that. We've talked a little bit about AI. I got to imagine that in imaging, this is going to be the first area that it really is going to hit hard.
I was going to say, are there other technologies or advancements that you're seeing or wondering that are coming, or anything new coming down the pipeline?
Well, we have, I think you're going to see some teleradiology.
Oh, okay.
The people in my center would kill me if I said this, but if you go to RSNA or you see what's happening in really the future in radiology, it's a technician in an office setting with 5 or 6 monitors running 5 or 6 different machines. And you just have an advanced tech aid there that's helped to position the patient and handle any issues that might be there, and they're going to run the machines offsite. And we brought a company in, so whenever we do contrast coverage, the state makes you have a medical professional there, like an RN or above, to be able to monitor any contrast issues at all. And we have offsite, we have It's called Tether. It's a group out of Texas, and you have a doctor on the other end of a line. It's on a stand on an iPad, and if you have an issue, they're talking to the patient and they're talking to you, and you could administer anything if there happens to be any
So
contrast
they don't have to
reactions.
be in the room.
They don't have to physically be in the room.
Oh, that's nice.
Right. So that cuts down on that. But, still, we don't want to go too far from that because, you still need, there's still big machines and there's still, quite a bit going on. So we're not in a rush to get rid of that. But if you ask me where it's going, I think it's heading in that direction.
Okay. That's fascinating.
Now, what are, from your angle, just like Lara deals with concierge medicine and what it is and the misconceptions of it, being that outside of the traditional hospital systems for imagery, what are the biggest misconceptions that patients are dealing with, or people that come to you are like, what are the biggest things that people are like asking you that necessarily aren't true, that just kind of throws people from going in your direction?
Right. The images are better at a hospital. Right. That's just insanity. It's the exact same or better equipment on our end, quite frankly, in some instances. That we can't, so we can put stuff in your My Chart at, if you're at a local hospital network. So if you have something done with us, it doesn't stay outside of the system. We can push and pull images back and forth. It's called continuation of care, right? So the other thing is that you don't need to go where your doctor recommends that you go. I mean, it should be up to you to make an informed decision as a patient consumer and be able to say, hey, listen, where is my money being spent? Because I think if you sit down and you look at these two images and say, one, I paid $4,000 for this one, and I paid $500 for this one, tell me which one is better. It's the same result. So I think there's a little bit of that. But I think that patients and specifically businesses, and this is probably what's going to happen with your industry as well, I think that the whole healthcare industry is moving into the independent primary care, concierge care, direct services as opposed to through the hospitals. And the businesses, if you look at kind of the businesses, I don't mean to take it into a tangent, but on the west side of the state, 52% of the medium to large businesses are self-funded employers, meaning that they've opted to do a catastrophic policy for their employees. But we think that we can spend our money more wisely and keep you healthier by using independent and navigate into a facility where they would go see people like you and your sister and go see people like the imaging center or go to a lab that's an independent lab, get services much faster and much more economical. We have one concierge group in town that started to use us from the beginning. And part of one of their services for their patients is to screen everybody. Mm-hmm. So we'll do cardiac calcium scores and we'll do like ultrasound, bellies and abdomens. And the last year, he's found 17 incidents of cancer.
That's crazy.
At the beginning stages and just killed them with a quick little biopsy. That's insane.
Yeah, because for people that are in healthcare, we don't typically, those aren't recommended by the large organization screening tests, so they're not typically done.
Right.
But they're finding things. Now, some people would probably argue that the cost-benefit analysis of that is not good enough. I feel like that's always what the argument is.
Yeah, I guess so. But, I can't get into his books, but I would say treating 16 or 17 cases of cancer is pretty...
Well, right. No, I mean, for those 70 people, it's amazing. And I don't mean necessarily for his books, but like for the healthcare system in general is always the conversation.
Well, I think the healthcare... I mean, look, let's not pull any punches here. We live in a community where one of the largest insurers is owned by the largest hospital.
Mm-hmm.
Yeah.
I mean, isn't that a conflict? They need people to be sick and do these certain things.
That's a good point.
And, and you are trying to make people be healthy and do things the right way. And I think that, it's just at odds with big business. And when big hospital becomes big business, it tries to keep people like us a little bit down, or we have a harder fight. And we're there, and I think that you see, I guess what I have noticed in dealing with this is that we're dealing with more people that really care about their patients, and that's not true in every aspect of the medical industry.
It's also interesting too, because dad, like my dad and I have these conversations. I was super fascinated to have you on because, like, from the different angles of my passion with, yeah, I love knowing. I'd love to be the 30,000 foot in every industry. Like, what's the legal at? What's the nutrition? Like, that's just what I love to do. And so, I just looked at it and like, okay, Dad, what was your perspective? He thought the best times everyone talks about it was the 90s. 80s and 90s in medicine and before, because you had the perfect, we'll bring this back to why America has the best governmental system in the world. You can argue individual people you may not like in positions, but from like a standpoint of, you have three branches of government, you have the executive, legislation, judicial branch, all checks and balances on each other. Inside the medical system, you had the doctors, you had the medical facilities, and you had insurers. And they were all three different branches holding each other to checks and balances. But when the 90s came in and the hospital systems were capable of starting to buy out the doctors, and then they started merging the insurers all into this one huge powerhouse, that checks and balances went away. And now you're just seeing the dumpster fire, which is unvetted, uncapitalistic control over things, and it's creating this dumpster fire situation. Like, because like you said, like there's one organization or a couple that basically have every three branches and they can just do what they want.
Yeah, right. So what is their goal, right? They feed each other.
Mm-hmm. And that's why, like, it makes sense where doing preventative imagery doesn't make sense when you're charging $5,000 for an image compared to $500 for an image.
And I think maybe so when we do some of those screens are like $150.
Mm-hmm.
I mean, they're not big things, but it's kind of a preventative situation. But you're right, you wouldn't go into the big hospital network and say, hey, let's do this. Someone's going to say, what the heck are you doing this for? So
it's like actually focused on the patient, which is a shocking concept, right?
Well, that's why you guys are ahead of the curve. You guys took a big jump to do that. I think I applaud you for that.
Well, thanks. And we couldn't do it without partners like you. Have been amazing.
Well, thank you.
Which is great. Now, when patients come to you, are there certain questions that you hear over and over again? Like, what are the common things that people wonder?
Well, I think they wonder, how long is it going to take? I mean, there are simple things. What should I wear? All that kind of good stuff. But we bill their insurance just like they do at the hospital network. I guess there is one thing, specifically in our centers, because we are on in a different fee schedule than the hospitals. Typically, when you come in, there will be some type of copay or deductible when you come in. I know that a lot of patients don't get that at the hospital sometimes. A lot of them are inpatient. A lot of them aren't. But I'm talking $20, $30, $40, not huge numbers. And believe me, at the end of the day, it's going to be $400 instead of $4,000. You have to trust that, you're not going to get a bill in the mail. You might not get a copay when you go to the hospital, but you're going to get a bill in the mail in 30 to 60 days. I think they want to know where they can see their images, and we have a PAC system that allows. A PAC system is our computer database that stores all the images. So when you have an image, it's called a DICOM. So if like DICOM, so that will be all of your shots of your CT or MRI, and those are called DICOMs, and those are stored in a PAC system. So our PAC system is how we deliver images to and fro. And when you come and visit us, you can also, if you wanted to, you can get a disc that we could burn for you that you could take to your physician. So if someone came in...
The only problem I have with that is who's got CD-ROMs? Like, because people bring me discs all the time, and I'm like, what the heck am I supposed to do with this?
Oh, you got to go back. You got to go through David's dad's closet and get an old CD-ROM from the cardiac center. We do this. Do you know how we get all of our referrals? Almost all of them. Faxing.
Yeah.
They all fax them in. So you tell me, well, faxing is secure. Well, not really. I mean, but we can email them in. How about, but they fax them in. I mean, just mail it. We'll get it in the mail.
It is funny how
let's bring horse and buggy back in.
I know, right? It is kind of funny. It's funny that we're talking about AI and then they're faxing all the documents.
Oh, I know.
So, I mean, there's a juxtaposition there that's really kind of unique.
I think my dad was still using a beeper until like 2018. So.
Oh, we use beepers in residency. I mean, that was not gone. Well, and you actually did need them because if you were in certain parts of the hospital, your cell phone service, it just didn't work. So they
Right.
actually still needed the pagers. I don't know if they still use them, but they were when I was
Kind of
there.
like a table pager. Your table's ready.
Yeah, exactly.
So what waiting room to go to, or what help room to go to?
That's funny. Well, what's next for the imaging center? Where do you
Well,
see this going?
I think that we are on the verge. Oh boy, I don't know if I can say it here, but we're on the verge of some big news. I think we may be getting another piece of equipment that's going to help, and we would be one of the only independent people in the area to have one, so we could compete maybe a little bit more in the cancer realm. I think that we're just trying to drive more. I think we're just trying to change the way things do, the way that the referrals come in and the order patterns. As far as we're 18 months in. So we started in the tail end of 2023, really opened the doors January 1st of 24. And, in the midway, we had some strategic conversations with cancer and hematology, which is really becoming one of the largest cancer groups in the Midwest. They're really dynamic, and they're fiercely independent. So I think they felt like maybe wasn't the right answer for them, and maybe I shouldn't say the name on you, but so they needed some help with really some independent imaging. So along the way, we built another center, which you were just in the other day. So I think what we're really trying to do is, get those running full speed and get the best talent we can over there, and be able to focus. And when I say that, when I sit down and meet with the people that we do a lot of imaging for, I'm really shocked at how interested they are in how well their patients are doing. I mean, that's kind of a unique thing. So I think we want to do some good. And I think that builds into relationships and partnerships, or strategic partnerships with other independent people like yourself, or like other labs and things in the area, to really try to create. I think that the whole concept, we started with imaging. The vision is a much bigger vision, to be able to offer independent services to people that don't have to go to the hospital or go through the hospital.
Love it.
Awesome.
Love it.
Well, as we kind of wrap things up, I want to make a complete pivot off the cuff. I'm just very intrigued, because we were talking before this conversation about health, nutrition, different stuff like that. What are you passionate about? Like outside of imagery, your business, like that, like what are you passionate about, like on the side?
Well, so I'm an older father. So I have an 8-year-old and a 13-year-old. I have 2 girls. So I'm passionate about them. I have a beautiful wife. I'm really starting to get back into health and nutrition a little bit. I'm a big guy. I've always been, on the bigger side. But I tell you what I've really loved about listening to you guys is you kind of cut through the BS a little bit, right? I mean, I've listened to not on the edge of my seat, but pretty close. I can't do the peck thing like you do on the other ones, which is really good. But I am in your seat, so I'm going to go ahead and take advantage of sitting in the seat.
Oh, I want to see the peck dance. Boom, boom,
right.
Boom.
I can't. I'm not afraid. I'm maybe late. Okay. That's for that after 9 o'clock.
You're looking too good with the jacket. I get it.
I know. I got to leave it on. So I really thought I'm passionate about business, but I think really being involved in this may sound a little bit corny, but I think that we're on the verge of changing the way that people are really going to vision a new healthcare. They're doing it in other states. Grand Rapids is slow to adopt these things. And I really think that we've got so much, people are coming out of the woodwork to talk to us. When we started to go around and tell people that we were going to do, hey, we're going to do this imaging center, and you're like, okay, great. Show me when it's up. But we got it up. And now they're like, holy cow, you guys really did that. What's next? And I think you get a lot of buy-in for a lot of people. And you guys are some of the first people that have done this as well. And I think you start to see something happen. So that's interesting. For me, I would say my golf game was of interest, but really not that much anymore. That's just gone away.
Well, we can definitely work on that, because this is Lara's first year golfing. So
yeah, I'm just learning.
Okay, I've been teaching Lara this year, so
left arm straight,
that's what
head down, keep your eye on the ball.
Oh, I hear all those things from David every time we go.
I think that's awesome.
That's fun.
Other passions, I'm working too hard right now, and I have too many. I should probably take my foot off the gas a little bit, but it's too fun.
Well,
That's a great question to ask.
Yeah, I love that. And I can't imagine how hard it was to get this business up and running. So I'm like, thank you for what you're doing at the Imaging Center. And we're excited for more. And you said there's now billboards up, so people are going to see these all over.
We do. We have 25 billboards around the Grand Rapids area right now. So you're going to see us pretty much everywhere. So stop. And, and the billboard strategy, if you've done one yet, hey, 6 words, you got to do 6 words. I'm a 14-word guy, but they say you got to bring it down to like 5 or 6 words. So that was tough to edit ourselves. But I think we get the point across, and hopefully, if you need imaging, we see you. We don't hope to see you, getting an image.
Well, awesome. Well, any other questions you have, David?
I appreciate your time on here, and I'm kind of envious of what is this called again? The tissue.
It's called a kerchief. I mean, do you want me to leave? Do you want me to leave one here for you?
Lara and I had a wedding a couple weeks ago, and I was looking for one that was just that color, and I couldn't find it, and I'm kind of envious of it. I'm not gonna lie.
Then we'll go ahead and set it up. Now you're gonna have to watch a little YouTube thing to figure out how to tie it. I don't fold them. You just got to be you just kind of got to make it look like it's,
Okay.
Like the messy hair that you spend too much time messing it up to make it look too messy, but not,
That's right. David wants to be just as classy as you.
I want to be just as classy.
Going back to what you said before, I would say it's my humility, David, that really kind of makes it. I would like to meet
I like you because you're not wearing a tie.
I did. I was told my first board meeting here in Grand Rapids, I walked in and I've got to wear a tie. One of the board members walked up and he said, "Take that effing tie off. You don't walk into a board meeting with a tie." And so ever since, I knocked the Chicago right off me and threw the ties in the drawer, and no more ties in town. So
that's what I like to hear.
Absolutely.
Well, hey, it was a privilege and honor for you being on here.
Well, thank you for having me. And again, you guys are knocking it out of the park. I love what you guys are talking about.
Well, thank you.
And it really makes a difference, because people aren't talking about this anywhere else.
Well, I've never heard anyone talk about what we talked about today.
Right.
Which I think is great. I mean, not great that we have, but it's great that we're talking about it.
Yeah, I think it is too. But the whole body, I mean, the way that you're, going after it, and hey, listen, it's health, and everybody's different, and not everybody's the same, and and don't be self-conscious about stuff, and be able to work through it. And I think that I think you guys have something here. I hope it really takes off.
Fantastic.
Thank you.
Thank you, John.
Well, with that being said, I hope everyone has a phenomenal rest of your day, and hopefully John will never have to see you in his imagery, but if you do, go to him.
You got it. Thank you. TheImagingCenter.org.
There you go.
TheImagingCenter.org.
Yeah, any other plugs you need? Or is that the main one?
MRI, CT, ultrasound, X-ray, and come and see us.
Perfect.
Fast and proficient.
Love it.
All right. Have a phenomenal day, guys. We'll talk to you soon.
Thank you.
Bye.
Bye now.
Bye.